Welcome back, friends. Today I chose for you this topic, which is an important surgical issue, and that's tumors of the small intestine. And that will include all the tumors that could arise from the small intestine, um, benign and malignant, and how we manage them. I tried to keep it as simple as possible, but I managed to get all the practical details that you will require to learn from uh, this particular topic. Now, tumors of the small intestine are particularly rare, and in general, if you take both benign and malignant, they constitute only 5% of all gastrointestinal malignancy tumors or neoplasia. And only 2% of the malignant GI tumors, so they are pretty rare and very quite uncommon. There is no one explanation to that why the small intestine is resistant to the process of neoplastic changes, despite the fact that the small intestine is quite long, and it's the longest part, obviously, of the whole gastrointestinal tract. Among these theories are the high turnover and rapid cell division of the epithelial layer, which tend to renew itself every 48 to 72 hours. The other possibility is the alkaline medium of the small bowel, and the last one is the low bacterial count in the small intestine. The small intestine is not sterile, but the bacterial count compared to the colon is very low. There are a couple of predisposing factors that could lead to development of small bowel tumors. And in this situation, it happened to be small bowel adenocarcinoma. And that can happen in patients with familial adenomatous polyposis coli. These are people who inherit a mutated gene, the FIP gene, which is inherited as an autosomal dominant trait and leads to multiple polyps in the colon, and also colon cancer and duodenal cancer that would arise from villus adenoma of the duodenum, which affects particularly the duodenum, but it could include the proximal part of the small bowel. So if the patient develop adenocarcinoma of the small bowel within the context of the familial polyposis coli, it tend to be the proximal part of the small bowel. The other disease that is known to predispose patients for development of adenocarcinoma of the small bowel is Crohn's disease. And in this situation, usually it affects the terminal ileum, i.e. the distal part of the small bowel. But these things are pretty rare, and they are not seen commonly compared with cancer of the colon. Now we need to know the differential diagnosis of this lesion when there is a lesion or a lump that's discovered in the small bowel on a scan or felt on clinical examination. There are only so many possibilities. And the majority of these would be, or the most common type, I think, is the carcinoid tumor or the neuroendocrine tumor of the intestine, and it will affect the small bowel. Mainly the terminal ileum. They also arise in the appendix, and we will explain the pathology a bit later. Adenocarcinoma can arise, and this is disease of the proximal small bowel, duodenum, and proximal jejunum. So it's more or less limited to that area unless the patient have got Crohn's disease. You'll find that often lymphoma can arise from the small bowel, and again, it's more disease of the distal small bowel due to the concentration of the lymphoid tissue in the terminal ileum more than the rest of the gastrointestinal tract, and this could manifest itself in the form of a single lesion, but it could be a lesion in the small bowel with usually multiple lymph nodes in the abdomen, where our role here really is to take a biopsy and ensure we give the diagnosis, unless it's causing a small bowel obstruction. Another important entity is the gastrointestinal stromal tumors. They are a lot less common than where they are in the stomach, which is the primary site for them, but they do happen in the duodenum and the rest of the small bowel. These tumors are characterized by the c-KIT mutation, which is the CD117 that's get targeted with molecular treatment. Majority of the gastrointestinal stromal tumors will be benign and small in size, and less than 30% of them will be malignant and will require some adjuvant treatment. Adenoma is a benign lesion that can occur in the small bowel, but they are pretty rare. The most common form is the villus or the tubulovillus adenoma that could happen in the duodenum or around the ampullary region, and in that situation, a lot of them do occur in the context of familial polyposis coli. Lipomas are seen every now and then, and usually they are asymptomatic and would be discovered incidentally. Very occasionally, they could be the point of an interception that lead to small bowel obstruction. Hemangiomas are pretty rare, but they do occur, and they can cause GI bleed in the form of occult GI bleed or iron deficiency anemia, and they tend to be difficult to diagnose. And these lesions seen in particular in specific situation, which is the Turner syndrome. Now, metastatic tumors to the small bowel are relatively common in the end-stage disease of metastatic cancers, such as cancer of the breast, particularly lobular type of breast cancer. Lung cancer can metastasize to the small bowel and lead to obstruction. Melanoma occasionally do metastasize to the small bowel, and also cancer of the colon, and to some extent urothelial tumors. They could cause metastases that lead to small bowel obstruction. So that's the comprehensive list for all the neoplastic lesions that could affect the small bowel. Now, we obviously want to know how do they clinically present. Now, in general, these lesions, majority of them will be discovered in one or two ways. One of them is non-specific symptoms of abdominal pain or nausea and occasional vomits. Other than that, they tend to be subtle, and they tend to be discovered either incidentally or investigation for small bowel obstruction. So unless they are causing small bowel obstruction, usually you wouldn't think of them as a differential diagnosis for abdominal pain, and the symptoms are mostly non-specific, and they occur in the form of abdominal pain, centrally located, and sometimes they can lead to small bowel obstruction. Every now and then we find these lesions are discovered on imaging, particularly on CT scan during investigation for either a non-specific abdominal pain or weight loss of unknown origin. And the CT scan will show a mass in the small bowel, and then we get investigated. Every now and then we discover them at laparotomy when we are doing a laparotomy for another reason, such as bowel resection or gastric resection or operation for a perforated diverticulum or perforated ulcer. And when you're on the small bowel, every now and then you encounter a tumor in the small bowel that will need further treatment. So in addition to small bowel obstruction, they could cause interception. And that's particularly seen in benign lesions such as lipomas. It could happen also in lymphomas and other benign lesions of the small bowel, where the lesion is usually located in the submucosa and work as a lead point for the interception that will lead to small bowel obstruction. Pretty rare, but it can happen. Every now and then they would manifest themselves in the form of occult GI bleed, where the patient is having either malignant or they are having iron deficiency anemia during the course of the investigation. When the upper and lower GI endoscopy are performed and no pathology was found, then you find that we will proceed for a capsule endoscopy, and that can discover ulcers or hemangiomas in the small bowel that is the cause of ongoing occult blood loss. Weight loss is pretty uncommon unless it's a malignant tumor or adenocarcinoma, usually of the small bowel, or malignant neuroendocrine tumor that could cause weight loss either as a constitutional symptom or as a result of partial small bowel obstruction and reduced food intake. And as we mentioned, anemia and small bowel obstruction, these are common scenarios for tumors that affect the small bowel. Now, we need to know the underlying pathology for these lesions. I'll start with the pathology of malignant lesions. If we start with adenocarcinoma of the small bowel, we will find that the mutations that lead to adenocarcinoma of the small bowel are more or less similar to that we see in colon cancer and pancreatic cancer, and in particular mutated KRAS or P53, or SMAD4, or the gene for hereditary non-polyposis colorectal cancer, or the deleted in colon cancer. And these types of mutation are the mutation that you will see in the adenocarcinoma sequence in the process of neoplasia of colon and rectal cancers. So it's no much different from adenocarcinoma that affect the large bowel, and it's usually a disease of the proximal small bowel, as I mentioned, unless the patient has got Crohn's disease. Gastrointestinal stromal tumors are the next category that we need to discuss, and these are in the past used to be called Leimyoma. But a lot of them are malignant to some extent, and it's probably 70% of them are small at the time of the diagnosis when they cause symptoms, and they get treated early in the course of the disease, and they behave in a benign fashion, and that's applicable to 70% of the patients. You'll find that the c-ketone cogene mutation is particularly prevalent, and it is positive in 90% of the cases. We also do a specific stain for a certain antigen, which is the human progenitor cell antigen. That's the CD34, and that's positive in 70% of the cases of gastrointestinal stromal tumors. Now, they are treated in the same way that we treat gastrointestinal stromal tumor of the stomach. If they are deemed benign, then surgical resection with a negative margin is all what we need to do for them. But if they are malignant under the microscope in relationship to their size, their mutation index, and their Ki67 index, then they get an adjuvant treatment after surgery, and that would be in the form of Imatinib. Now, lymphomas in general, the most common ones that I have seen are diffuse large B-cell lymphomas. And obviously this is a medical treatment, and our role most of the time is to relieve small bowel obstruction or obtain a lymph node biopsy to establish the diagnosis, and then the patient get treated for their lymphoma. Now, neuroendocrine tumor are particularly important in the small bowel. They are diseases that affect mostly the terminal ileum. They can be multicentric in about 20% of the times, and every now and then we see them associated with cancer of the colon, and has been reported that on average about 15% of patients who have carcinoid tumor, they might actually have a coexistent cancer of the colon. Hence, when this disease is diagnosed, we often follow the surgical treatment with a colonoscopy to rule out colorectal neoplasia. A particular phenomenon in carcinoid tumor is the fact that the primary lesion tend to be small, while the lymph node metastases tend to be larger in size, and usually is more, in fact, symptomatic than the primary disease. A lot of the carcinoid tumors are indolent, low grade, and they are compatible with a lengthy long-term survival. So while we are at the classification of the neuroendocrine tumor, we have to know their classification, and it is the same classification that the WHO uses for the pancreatic neuroendocrine tumors, and that divides them into three categories: grade 1, grade 2, and grade 3. And this is based on, number one, the degree of differentiation of the tumor. Number two is the number of mitoses per 10 high power field. And number three is the Ki-67 proliferative index. And these ones are relatively easy to remember because it's the mitosis less than 2, between 2 to 20, more than 20 per high power field. And the same thing applies to the Ki-67 index, less than 2%, 3 to 20%, more than 20%. There is a fourth variety, and it's called small cell cancer, which is extremely rare. It's very malignant and aggressive disease, and the treatment for it usually, in most of the instances, in fact, is palliative, but they can receive chemotherapy similar to the regime used for small cell cancer of the lung. But they are pretty rare lesions. Now, there are a few benign lesions that you will encounter in the small bowel, and probably the most common that we see is adenoma. And there, when we say adenoma, we mean the villus adenoma of the duodenum that happen in patients with familial adenomatous polyposis coli. These patients tend to generate a lot of villus adenomas, which can be pre-malignant. So you find these patients will have regular gastroscopies to check them for adenomas, and if they are present, they get removed, and on occasion they can be resistant to removal and they recur, and they can be of large size and high grade, and some of these patients will progress to have a duodenectomy. But that's a rare indication to remove the duodenum or to do a Whipple resection, but it could happen in these particular patients with familial polyposis coli. The indication and the pathology of the villus adenomas is classified by a classification which is called the Spiegelman classification, or grade, and if it's grade 3 or 4, then they need surgery, and hopefully I could cover that topic in a later lesson. A famous known disease called the Peutz-Jegher syndrome, and that's autosomal dominantly inherited disease. It was thought in the past that it only causes hematomas in the small bowel that can lead to interception or GI bleed or iron deficiency anemia. These patients are characterized by melanotic pigmentation of the lips, the buccal mucosa, and in other parts of the body where you can, when you see them, you could support the diagnosis just from these melanotic lesions. in the mucous membrane. These lesions are totally benign, but these patients, they have been found to have high risk for developing a variety of cancers, mainly extracolonic cancers, and in particular cancer of the small bowel, the pancreas, the stomach, and possibly the ovaries. They can also lead to ulceration and GI bleed, and sometimes that can be challenging in particular terms when we are looking for the site of the bleeding to do targeted resection of the small bowel. So it can be a challenging clinical problems. This disease is rare, but it is a risk for cancer. Hemangiomas, as I mentioned before, they seem to be particularly common in patients with Turner syndrome, and they lead to gastrointestinal bleed, usually in the form of occult bleed, that will need to be investigated to discover the site, and we will cover how we investigate the small intestine for occult bleeding or occult lesions. Now, the workup. You find often that these patients, the workup depend totally on their presentation. They could present with small bowel obstruction, and by then they will have had a CT scan that showed a mass or just obstruction of the small bowel that in a patient who had no previous abdominal surgery. They get explored and we find the tumor. If we're looking at adenocarcinoma, PET scan is prevalent these days, and we often get a PET scan for them. And the other important application for the PET is if we think the lesion is caused by lymphoma. And PET scan plays a crucial role in staging of lymphoma. We do tumor markers, but these will be of limited benefit, but we can use CA for adenocarcinoma. The role of that is not clear because of the rarity of the disease. However, Chromogranin A, which is the same tumor marker that we use for neuroendocrine tumors of the pancreas, it's a good prognostic point. We use it mostly in the follow-up rather than in the actual diagnosis. A rising level of Chromogranin A in the postoperative period could indicate recurrence of the disease. And if we think they have got carcinoid tumor, currently we do a Gallium PET, and the Gallium PET is very sensitive for detection of the extent of the neuroendocrine tumor in its primary stage, and also to find distant mutations. Now, occasionally the diagnosis can be challenging in patients who do have non-specific abdominal pain or ongoing diarrhea or ongoing iron deficiency anemia from occult blood loss. They might need to be investigated further. Before I move to that, I will mention to you the typical appearance of lymph node metastases and carcinoid tumor, which gives you the appearance on CT scan of a sunburst sign with calcification in the center of contracted scarred mesentery caused by the neuroendocrine tumor that secretes serotonin and prostaglandin, which lead to extensive fibrosis and shortening of the mesentery in the region of the involved lymph nodes. Now, push enteroscopy can sometimes be utilized in occult GI bleed. It's not commonly used because it's quite a labor-intensive and difficult clinically to implement. However, we have also a capsule endoscopy, which can be swallowed by the patient and then get retrieved afterwards. And the movie that is obtained from that camera and the capsule get analyzed to see if there is any lesion in the small intestine, which in fact has revolutionized the field of investigating patients with occult GI bleed. Red cell scan is used every now and then, but they are particularly they're not particularly helpful to find the source of the bleeding. However, if the bleeding is caused by a hemangioma, because hemangioma tend to have a sluggish blood flow in it, red cell scan can be beneficial in that situation if you are suspecting hemangioma as a cause of GI blood loss from the small intestine. Every now and then we consider the role of a CT scan or MRI enteroclysis, a special protocol on the CT scan or the MRI to investigate the small intestine, and in particular MRI is quite useful to localize a lesion in the small intestine that cannot be discovered on conventional CT scan or MRI. Often you find that doing these investigations will be enough to pinpoint the diagnosis, and then the treatment will entirely depend on the type of the histology that we get. So as I mentioned about the treatment a bit earlier, if it is an adenocarcinoma, and as you will remember, it's disease of the proximal small bowel and the duodenum. Usually the patient will get segmental resection of the cancer with adequate lymph node dissection, and occasionally we find the lesion is too advanced, and then the patient will benefit from a bypass and some palliative chemotherapy. Now, if we resect them and it's adenocarcinoma and no distant metastases, then there might be some benefit from adjuvant chemotherapy. This area is not studied very well due to the rarity of the disease, but you will find our medical oncologists often use the same chemotherapeutic agents that are given to patients with colorectal cancers. Carcinoid tumor is totally different, and it's usually treated again, the same principle, by segmental resection and removal of the lymph node. Debulking surgery in cancer is not a common thing to do, but it is a viable option for patients with carcinoid tumor. If we can remove the primary and as much as we can of the lymph nodes, there will be a great benefit to them. Occasionally, the metastatic lymph nodes could be located in a difficult spot, particularly if they lie along the origin of the superior mesenteric vein and artery. The area can be quite risky for dissection, where we could remove a residual disease that could get treated with adjuvant treatment. If there are liver metastases, we also resect them as long as we can remove 90% of the bulk of the tumor. Carcinoid tumors are not very responsive to chemotherapy. A variety of regimes have been tried in the past, including sirolimus and doxorubicin and a variety of other chemotherapeutic, usually alkylating agents, but the benefit seems to be limited. However, adjuvant octreotide, which is a somatostatin analog, synthetic analog for the hormone somatostatin, seem to be very effective to control and slow down the growth of recurrent or residual disease. It's also useful to combat the symptoms of carcinoid syndrome when we have malignant carcinoid syndrome due to secretion of a variety of hormones, which I will explain to you in a minute. So adjuvant octreotide is given in the form of a monthly injection for these patients with residual or recurrent neuroendocrine tumors or carcinoid tumors, as they were called in the past. Now, as I said, the lymphoma, our role mainly is to obtain a biopsy for the medical oncologists or our hematologists, or we take lymph node biopsy to establish the diagnosis so they can give their medical treatments. Gastrointestinal stromal tumor is the other possibility, and these ones are usually segmental resection. We don't worry about dissecting lymph nodes because the risk of lymph node metastases with gastrointestinal stromal tumor is very small. it's probably less than 10%. So we rely on just resecting the tumor. And then the patient get discussed and the multidisciplinary team to consider the possibility of giving the patient adjuvant treatments in the form of Imatinib or Gleevec. And that will be dictated by the size of the lesion, the mutation count under the microscope. And if these patients are suitable and we think they will benefit from adjuvant imatinib treatment, that's when they are malignant, then they will get adjuvant imatinib for these days. We give them for 3 years. Because we had the carcinoid tumor, I thought I explained to you what carcinoid syndrome is. I find that anytime we have a patient with a neuroendocrine tumor of the intestine or the pancreas, or junior staff get excited about carcinoid syndrome, particularly anesthetic residents. They start reading about what could happen to the patient with carcinoid syndrome and carcinoid crisis. Now, carcinoid syndrome is a disease that will happen in patients who have liver metastases. It will not happen in a patient who does not have liver metastases, or except 2 occasions. Carcinoid tumors could happen in the ovaries and in the bronchus, and because in these situations, the tumor will drain into the systemic circulation, not to the portal circulation, you could have carcinoid syndrome without liver metastases. However, if it is originating from the pancreas or the gastrointestinal tract, you will need to have liver metastases for the patient to develop the carcinoid syndrome. Now, clinically, the carcinoid syndrome is composed of 3 problems. It's a vasomotor or cardiac or gastrointestinal symptoms. The vasomotor are related to vasodilatation and vasoconstriction by a variety of hormones that get secreted by the tumor. And these hormones are serotonin, histamine, kallikreins, and prostaglandin, and other variety of proteins. So these patients will have cutaneous flushing, high blood pressure, or asthma, and extensive wheezing from the reaction they get in the bronchi. Carcinoid syndrome, when patients have liver metastases, we get worried about tricuspid valve damage because of the effect of prostaglandin and the other hormones, mainly serotonin, that will lead to fibrosis and shrinkage of the valve, which will lead to incompetence of the tricuspid valve or stenosis of the pulmonary valve. They do also lead to a variety of arrhythmias, and they could lead to hypertensive crisis under anesthesia when the patient is having the tumor manipulated and removed. That's why the anesthesia has to be aware of the risk of developing hypertensive carcinoid crisis during the operation. Also, due to the same hormones that get secreted by the tumor, the patient could develop diarrhea and they can end up in a full-blown malabsorption syndrome with deficiency of a variety of nutrients, vitamins, and trace elements. You'll find that patients with the carcinoid syndrome, they will respond really well to the treatment with octreotide in the form of injectable medications. It will control their symptoms, and it will also control the growth of the tumor when the patient have residual non-resectable disease. Thank you much for seeing my video, and keep tuned to us. We will have more and more lessons with regard to a variety of issues in surgery and surgical care. Thank you much again, and I look forward to see you in the next lesson.